dealing with abilities for 13. And, you know, we specialize here working with children with autism. So we do see a lot of children with sensory processing disorder. And that's what we're going to talk a little bit about today. A lot of times it's kind of a hidden problem. And, you know, I definitely recognize that sensory processing disorder is a unique disorder. So it coexists with other things. And so, you know, the more and more I've worked with children with these kind of issues, it's great to collaborate because some of the things that I do, I need assistance on your end, and some of the things that you do, you might feel like something's missing or we're not getting quite to where we want to get. So I've been dealing with children with sensory processing disorder pretty much my entire career. And it's a really wonderful area because we have been able to help so many kids in so many different ways, and you can really change their lives from early on. So the earlier we get them, the better. So today what I was going to do is just kind of introduce you to it so that you know when a parent comes to you and tells you these things that are going on, that you might be able to recognize a red flag for it. And in your little folders, I've put checklists that you're welcome to make copies of. I don't know where they put in the folders. They look like this. And we'll kind of go over them too. But basically, if you have a parent that comes to you and starts telling you these things that are related to sensory issues, that you can start to be able to recognize clusters of behaviors that may point to one of these areas, and then refer them to us so that we can do actual, you know, further assessment and treatment of them. How many of you are familiar with sensory processing disorder? Have you heard the term? Yes? A little bit? Okay. I mean, basically, we process sensory information all day, every day. All of us do. And sensory processing is just the central nervous system taking in and receiving sensory messages and turning it into a response. Okay? So sensory processing disorder is when the nervous system is not doing an efficient job of that. You know, we have our typical systems. We're going to talk about sight, sound, smell, taste, and touch. But there's two systems that we deal with as ATs that are kind of called the hidden senses. And this is the vestibular sense and the proprioceptive sense. So in some of our reports, you'll see proprioception and vestibular. And these are more related to balance and movement. Okay? So basically, our body has receptor sites. Okay? So you take in the information for sight, it's your eye. For sound, it's your ear. For touch, we have touch receptors all over our skin. For the vestibular system, it's your inner ear, okay? And it's how it processes incoming information, and then, you know, you have balance reactions and that kind of thing. And then proprioception is muscles and joints, okay? So a lot of the kids that we see may be having problems with those areas, and it's kind of hidden because you don't really think about how much our brain relies on that information until you have a problem with it. Okay, so I've put on here kind of how the most current research and how they've broken down sensory processing disorder. This is a great book, Sensational Kids, by Lucy J. Miller, and I think I put it on your resource sheet, but she's excellent with, she's done a lot of the research in Denver at the Star Center, and it's a great read. It gives you a good clinical picture of different kids with different sensory issues. Okay, so when we talk about sensory modulation disorder, these are the kids that are over-responsive to sensory stimulation or under-responsive, okay? So it can be over-responsive to touch, over-responsive to smell, over-responsive to sound. If it's vestibular, we're talking about children who are car sick, who cannot tolerate movement, who cry because they have to go to the playground, who have poor balance, who are clumsy, who fall out of their chair, those kinds of things. And then when we talk about under-responsive, these are the children that it takes a lot of sensory input before it registers. So they're the child that's going to have high pain tolerance. You know, the mom says, we call his name 10 times, he doesn't respond. Or he falls out of his chair, and it's like he didn't even notice. And so we see those children as well. And then the SC is for sensory craving. And these are the children who seek out greater amounts of stimulation than most children their age. So keep in mind that, you know, we all process sensory information. We all have sensory preferences. We have sensory aversions. And kids do as well. It's when there are clusters of behaviors and issues that interrupt their ability to function daily. So if they're having, you know, if a child has one or two issues, they don't like the seam in their socks, we're not going to diagnose them with sensory processing disorder. It's when their entire life is affected by it. Okay, so modulation, you know, the brain, the receptor sites take in the sensory information, and then we orient to it, and then the brain decides, should I pay attention to it? Can I ignore it? Or do I want to explore it further? Okay? So when you're thinking about all the different senses, the brain does this with each one. If, you know, like for the tactile system, we have a protective sense and a discriminatory sense. So if you have light touch on the back of your neck, the brain is designed to alert you to that. It may be a bug, it may be a spider, something to alert you of danger. We would react to that maybe by slapping at it or scratching it or hitting it. If someone bumped into us, our brain would say, someone bumped into me, it's not a big deal. But for a lot of our kids, they're over-responsive. So it barely takes any intensity of input, and then their brain overreacts to it, and then the response doesn't match the intensity of the input, okay? So one of the biggest things we see with children who are hyperactive and children who are hands are on everything, or, you know, they cry or they punch kids. I mean, we get, you know, my child is so sweet, I don't understand why he punched this kid in line. But we see that a lot. And so we're looking for different groups of responses that they have that point us to touch defensiveness, okay, or sound sensitivity, or, you know, sensitivity to movement. And for these kids, it can affect them stepping up a curve, getting on an escalator, you know, just getting on a swing on the playground. So all of these things are very important to look at early on. And as we go through the discussion, think about how sensory affects you and your sensory preferences and your sensory aversions. So on one end of the spectrum, you know, my husband loves roller coasters. He's a risk taker. He's on that end. I'm on the end where I'm always car sick. I don't like movement. I don't like changes in head position. So I've had to come up with coping strategies to help deal with those things. A lot of times kids are not able to tell you that. And so you have to look really closely to find that. Also with modulation, and we'll talk about sensory diets later, but think about yourself every day when you wake up in the morning, what types of sensory activities you do to either increase your alertness or decrease your alertness, okay? So, you know, in the morning you may take a hot shower, read the newspaper, go jogging, listen to louder music to get you alert. And then when you're on your way home, you get in the car and you're like, I can't believe this radio is so loud. What was I thinking? But you need everything to kind of go away. And so we use a lot of these theories and principles to kind of help teachers and parents recognize, you know, right now this child is overwhelmed, overloaded, and these are the things we can do to help them to be able to stay at school today. Okay, then you have the sensory-based motor disorder, and this is dyspraxia and postural disorder. So dyspraxia, praxis basically is the ability to generate an idea and then plan the steps, sequence the steps, and then execute the motor activity. So anything like putting on a coat, tying a shoe, everything we do requires praxis. It's an innate human ability. Kids can have breakdowns in any area. They can have a breakdown with they can't generate any ideas for play. So sometimes we'll see a child come in, they look like they have a short attention span, but really they can't come up with anything more to do with a toy. So, you know, a typical child will sit down, play with a toy, come up with different ideas, change what he does, use language. A lot of our kids will come in, they have no clue what to do with toys, especially novel things, you know. So our brain over time, it compares what we've done before, and your body knows kind of what to do on this novel piece of equipment, like an inner tube swing or something that you haven't encountered before. And these kids really have a lot of problems with, sometimes you see pretend play is not there. they just get kind of stuck. But then if we give them the idea, maybe motorically they're fine, and then they can go through the steps that way. A lot of our children have trouble motor planning and sequencing the steps, so we can address that area. That is one of my favorite kind of kids to work with, because a dyspraxic child is usually very clumsy. They feel very inadequate. They have low self-esteem because they feel like they can't do anything right. So if you can think of, if you learn how to ski, or if someone was going to teach you how to knit or tie these different kinds of knots, anything, a new dance step, and you feel it's so hard to kind of learn it, everything they do every day requires them to plan it out, and it's not automatic. So our goal in therapy is to basically teach their body, their brain, and muscles how to do things more automatically so they can focus on higher level processing. Postural disorder, that's talking about children who have like low muscle tone, so they can't stabilize their bodies in ways that they can work efficiently. They lean on their head, their hands under their heads all the time. They slump, they fall out of their chair. They find it difficult to sit upright in circle time. And so we'll look at, we have specific assessments that we do to consider, is that an issue? Is it more of a postural issue or a sensory issue, or both? Okay, and then when we talk about sensory discrimination disorder, there are all the sensory systems. This is discriminating between qualities of sensory input. So whenever if the music is too loud to you, that's modulation, over and under responsive. Discrimination is more, can I put my hand in my purse and find my lipstick without looking, okay? Is it, how high is the curve? How hot is the stove? So you're looking at discriminating different qualities of each type of input. And so we see, we have assessments that we use that can help us to diagnose these things. And, I try very hard not to overdiagnose, but, I have enough experience at this point where we can kind of pinpoint it. We do have the SIPT test here, which is the Sensory Integration and Praxis test. It's a wonderful assessment, but it takes a long time to administer, and it costs a lot of money. And so parents are kind of like, well, we just forego that and, see what you can tell us based on your other assessments. But the SIPT is great for children who are like between 5 and 9, who really we can't pinpoint. It's very subtle, and they may have learning disabilities. A lot of the kids that have these kind of issues have learning disabilities as well. So the SIPT is good for that. As far as causes, some think it's genetically linked, which we do find that parents of children with sensory processing disorders, once we start talking about all of this, they start to recognize it in themselves. It can be prenatal conditions, birth trauma, prematurity. A lot of children with premature nervous systems end up having sensory processing disorder. And then possibly environmental factors. But they're doing a lot of research. Lucy J. Miller, they're doing a lot of physiological research, and they're studying threshold levels of chemical synapses to see, the gating function, where exactly how much input for this child did it take and what physiological responses they have, and they're actually measuring that. So I know, as far as research goes, a lot of people want more, clinical research, but a lot of the research we have is moving that direction, and I do have the Spiral Foundation on here. That is a great resource to go to. It's pretty much the sensory integration research website. So you can go there and get access, to all the different research that they've done. Okay, as far as diagnosing it, we definitely look heavily at questionnaires. So we get questionnaires from the teachers, we get the parents to fill it out. If the child's old enough, we'll ask the child. We do have questionnaires for adolescents and adults. We usually don't see people older than 21, but we have had 16, 18-year-olds come in, and we help them as well. Even if it's to make accommodations or to teach them strategies to use. But we use the SPM, which is a sensory processing measure, and that is a standardized test. the SIPT if need be, and then we look at mainly clusters of behaviors. So that's the biggest thing to look for. When you hear parents say things, you want to be able to recognize, ooh, that sounds like he's sensitive to touch. Because children who are sensitive are usually overly active, and it can present like ADHD, and it may be ADHD. I mean, there are two separate disorders, but many kids with ADHD present with sensory issues. So we want to really tease it apart and figure out what the underlying problems are, and then treat those accordingly. Okay, emotional impacts. Definitely we see low self-esteem. We see anxiety, we see depression, lots of difficulty making friends in social situations, very poor emotional regulation, and most often what I see is that the parents feel like they cannot go anywhere with their child, you know. And so one of the biggest goals for us is to hear them come in and say, we were able to go to a birthday party, or we were able to go to a restaurant, or we went on vacation with another family, you know. And it affects the entire family. And this book is great because it goes through a day in the life of 4 different children, and it shows how it impacts the parents, the other siblings, the friends. And so it gives you a good picture of how disruptive it can be. You know, and really we're still working to get people to just identify it and be aware of it and validate it, because, you know, we'll talk about autism also, but it's impossible to avoid it. Like, now that we know it exists and we know we have treatments that help it, you have to at least recognize that it's there. And I'm the first one to say, if it's not sensory, it's not sensory-based. You know, I'm fine with that. But if it is, there's things you can do to really improve the quality of their life. Okay, so if you look at the little checklist we have, there's one for 0 to 3. They look like this. There's one for 3 to 5 and for 5 to 12. These would be great. You can add this to your assessment if you hear some concerns from the parents that show some red flags. This is great, and you can email this to us or fax it, and we can look at it and tell you, yes, we think there possibly might be something, or no, it looks like it might be something else. But if you look under each one, like dressing, bathing, and touch, you know, infants from 0 to 3 can already show signs of this. A lot of times colicky babies end up presenting with sensory issues when they get older. But, you know, the kids don't want clothes on, they want to be naked, they can't stand to have their teeth brushed, their face washed, their hair combed, they're extremely sensitive to pain, they overreact to pain. Or if they're unresponsive, they don't notice pain at all, they fall and cut themselves and they don't even know that they did that. And so you can imagine every day they'll change their diaper, and it's, you know, and again, we look at typical 18-month-old, you know, they're laying on their back, they fight, they want to get up. But if there's not other things coexisting, then it's just typical behavior. When you look at movement, you know, we're looking for kids who are constantly in motion. And again, it may be ADHD, and there's ways that we kind of look to delineate that. But if you have a child who's, you know, I have a little boy right now, he's 4, and to go on the playground in the heat, he's very tactily defensive, he's very auditorily sensitive. It's like a total nightmare. I mean, he melts down for 45 minutes just at the thought of it. And so the teacher calls the parent, and the parent's crying because, you know, he's starting to melt down all the time during the day, and it's just too much stimulation for him. He can't handle it. And he's come a long way, but it's not normal for a 4-year-old boy not to want to go play outside. You know, so that's a red flag right there. Sensitivity issues with sound and language. If the parent says, you know, we can't go to the public bathroom because you flush the toilet, they scream and cry and fall apart. Music in the car, they might not allow the parent to have music on. Or they're very distracted by sounds that we don't hear. You know, so for us, the air conditioner could kick on, our brain will hear it, respond to it. It's just the air conditioner, and we'll go back to what we're doing. It can inhibit it. But for these children, they get stuck on the air conditioner, or on the fish tank in the classroom, or the person cutting grass outside. And so we do have programs here that actually work to reduce sound sensitivity. and that has been very, very successful. If they're sensitive to bright lights, we might recommend that the parents let them wear sunglasses or a hat. I mean, they have everything imaginable that you can think of to help with all these things. They have baseball caps that have a weight placed underneath the top because pressure is very calming, especially for children with touch sensitivity. So they might have a tight little belt in their hat, and they have a heavy backpack, and they're much better. Okay, so each of these kind of goes through those things. Look at play, look at emotional regulation, self-regulation, attention, and then we look closely at eating and sleeping to see if that's related. And we work closely with physicians, you know, if their treatments are effective, then we know that was the problem. But a lot of times they'll come and say, we don't know what to do. And so it could be, there's a lot of kids who are very restless because they're sensitive, like they like heavy blankets. If we put something oscillating in the background that has a noise, a rhythmical noise, then they can sleep better. So we have strategies for every kind of daily living skill that the parent has to deal with. Okay, any questions on any of those?
I just had a question. I know you had addressed a lot of the issues with the parents. How has it been with the school as far as making those accommodations? Have they been receptive at all to knowing
It
that
depends on the teacher.
Okay.
It really does. And what I've learned over the years is I have the teacher email me specific, like what are the priorities, and then I'll give her specific recommendations on that. And usually if that's effective, and something else comes up, and then they're like, do you have anything for that? And then it kind of builds, you know, but they have to be open. I mean, there are some who, no matter what you try, they're not going to do it, and usually it's not a good fit for the child, and it doesn't work. But for the most part, they're pretty open. You know, I mean, I can tell them sometimes if you let him chew on a little piece of mint gum, his behavior will improve a lot, and they won't do it. You know, so it's like, well, okay. You know, you can't push them, but I mean, I'd love to get in a lot of classrooms and have things available for the kids who need it. So it doesn't have to be this child comes in and brings it, but maybe on that day a child needs a little air cushion to sit on, to wiggle around on, or a fidget in their hand. You know, we have lots of different fidgets that we try and match to the child. We put Velcro under their desk so that they can scratch and rub on something, do something with their hands without being disruptive. And we try to explain to the teacher too, if that doesn't work, it doesn't mean that something won't work. It's just that particular thing didn't work, you know. So, but we've had a lot of success. I mean, the Northeast has had great success there in all the classrooms everywhere. In California, you know, we're still working on it. Okay, so we do see this present in a lot of children that are gifted. So, you know, they have this higher mental processing speed, faster, you know, they're hyperacute, and so all their sensory systems are hyperacute as well. And we see that a lot, that they're brilliant children, but they can't function in the classroom. And so there's a link there, and a lot of times if we identify what the problems are and we give them the right supports, and I mean, a lot of it is educating. You know, you educate the teachers that this child does not like when you lightly touch their hair, or when you put them in the middle of a crowd, and then the teacher knows what to do if the child does get overwhelmed. You can save that child from falling apart that day. So educating them, giving them options and things to try has helped a lot of gifted children. Because a lot of parents are like, I don't understand, he's so smart. It's like, well, there's a lot more things in the classroom that you have to be able to tolerate than just academics. You know, so we do see that. With autism, I mean, again, they're two separate disorders, but about 3/4 of the children that we see with autism have some type of sensory processing disorder. Most of the time, they are over-responsive, and they just shut down, but there are children with autism who are under-responsive, and they have very poor registration of sensory information. So they look like they're totally zoned out, tuned out, but if we do techniques that really emphasize our voice intonation, or the games that we play, or we increase the intensity, we do bright lights and we do loud music, then we can kind of engage them a lot better. And we start to give them a sensory diet of lots of movement and sound that increases their ability to register. input faster. We talked a little bit about adolescents and adults. A lot of times it's more teaching them about self-understanding, about what's going on, that they're, you know, the several that I've worked with, they're really appreciative that somebody finally gets them, you know, that they're not crazy. And we made some good accommodations. I mean, a simple one would be this one girl, she could not do independent math work in the classroom. She just couldn't do it. Like, she could not handle any noises, whatever. So the teacher allowed her to have earbuds and let her listen to this particular music that was very organizing for her, and it worked wonderfully. So it wasn't that she couldn't do the work, she just needed that support. So we try really hard to match, take their preferences and match it to what they need. And you know, there's a lot of adults who had sensory processing disorder and never was diagnosed, never was treated, and many times, I mean, they're depressed, they have trouble working in their relationships, you know, it just keeps going. And so we can still help them. It may not be as remediated as with the younger children that we see, but it is definitely helpful in improving their quality of life. Okay, so as far as occupational therapy, I mean, I don't know if you all are familiar with exactly what we do, but you know, we're here to help these children to be able to do whatever they're expected to do in whatever context they're expected to do it in. So we do see children who are in a private school and they look totally normal and everything looks great and they're struggling in the classroom. And so we try and look at what those issues are. Even though they may not be severely involved, they still have issues that we can address with supports and they can do well. Sensory diets we use often to help the parent or the teacher figure out what sensory strategies can we use throughout the day to help that person to be able to stay kind of regulated throughout the day. So we look at what the child prefers. Are they a jumper? Do they like to put everything in their mouth? Do they touch everything? And then we look at different preferences. What do they like to put in their mouth? You know, is it sour? Is it sweet? Is it sucking on something? And then we figure out, okay, in the morning before school, they're going to jump on the trampoline, and we're going to give them this kind of breakfast, because crunchy and chewy is a type of proprioceptive input, which is like to your jaws, that's calming and organizing. So proprioception is a great way to get a child organized and calm. And so we might incorporate that. We might incorporate, you know, if they're a low arousal kid, we might put a certain kind of music on in the morning to alert them. You know, and so there's lots of different things you can do. Then we look at school and figure out what the teacher will allow, what's acceptable, and how can we give them something to replace whatever they're doing that's not appropriate. And then modifying the environment's a big one as well. We'll talk to the mom about, you know, what does their room look like? Or where are they studying, do their homework? You know, homework's a nightmare for a lot of kids. And just by, you know, okay, if he sits on a therapy ball and he chews bubble gum and he has this particular kind of music on and there's not a lot of visual distraction, he does his homework well. You know, what does he need? What combination of sensory inputs can we give him to be able to function optimally? And that's so. And then I have a sheet in here about SPD and ADHD. Which one or both? A lot of times we see, you know, it's very close. It's like hard to tell. So I've been talking with Dr. Razafi about it as well. And it's like, well, you know, sometimes we will give the child sensory input because they look like they're a sensory seeker and it doesn't seem to help. Or it's not improving the impulsivity. Or, you know, some of those things real specific to ADHD. And then they try medication and it helps tremendously. You know, like my child is on medication for inattentive ADHD. He doesn't have sensory issues. And so, you know, I mean, he could sit on a ball and it might help him a little bit, but the forgetfulness and, you know, distractibility and none of that was helped with those things. So we put him on Concerta and it helped beautifully. But then we have some children who you put them on medication and it exacerbates the sensory issues. You know, so then you kind of like, well, it's not helping, we're getting more side effects. Is it more of a sensory-based issue? And so you just have to work closely together to figure out. But you can look like if they're not as impulsive when the sensory input is sufficient or right, then it's probably sensory seeking. But if they're still impulsive regardless, then it's probably ADHD. So you can look through those. They have this chart in here, and then they have one on SPD and inattentive ADHD. And that's more kids who might look low arousal or daydreamy or that kind of thing. Okay, any questions so far you can think of? I mean, today I'm just trying to get you aware that it exists, and the resources that I put on the back page are really great. The spdfoundation.net, you can get as much information as you possibly want. I did look up a few psychology websites that have actually put blogs and information about sensory processing disorder. Let me see, the Asperger.net is really great. You see a lot of kids with Asperger's, you know, they're gifted academically, socially, a lot of problems, very hyper-perceptive, very emotionally dysregulated kids. But even if they don't have Asperger's, I get a lot of tools from that website as far as sensory processing. This is a good little book too, Asperger Syndrome and Sensory Issues. It's a real easy read about sensory processing and how it relates to kids with Asperger's. And I mean, we have tons of strategies that we use. So I put in here two different handouts, well, three actually. One looks like this, tactile defensiveness, and then it has the observation, kind of what you would see, an explanation of what that might mean, and then what would one of the interventions be. So it kind of goes through a lot of different sensory issues that you might see, and it helps you recognize, okay, if they dislike having their face washed, their hair cut, and they freak out when they go to the hairstylist, it might mean that they're sensitive to touch, and you know, we can do like firm compressions, touch pressure is very inhibitory. So for kids who are aversive to touch, you want the parent to know that firm pressure can help desensitize them before they get their hair cut or wash their face. And so this is helpful. I mean, this would be good just to look through, and it gives you information about what the behaviors might mean.
Can we steal these?
This is all for you.
Like,
Oh, yeah? Oh, absolutely. Absolutely. And then there's, this one's really good. Suggestions for parents and teachers of children with sensory processing disorder. It kind of gives the area like tactile defensiveness, and then it lists lots of different things to be aware of, whether it's just, I mean, a lot of it is just how you interact with the child. And if I can get the teachers, even the parents, to look at the child from a different perspective, that they're not just being obnoxious or trying to annoy you or trying to drive you crazy. They look at it from a little different lens, and then they can understand it a little bit better, tolerate it a little bit better, and then they try some of these things. And then, I mean, we make a lot of improvement through direct therapy, you know, but then this is kind of to carry it over at home.
can I ask a question about
Yes.
that? What could I tell a parent who's considering doing sensory integration therapy, say here, about what they can expect in terms of getting better, as opposed to strategies that actually
Yes,
fix
no,
it?
we can definitely improve. I would have to say that, I mean, I've seen some kids since they were 3, and now they're like 15, so I've been able to see kind of longitudinally what has happened. I find that we can really resolve the functional problems, that they're still a little quirky with those things. They still might have strong preferences, but as over time, as the child has learned strategies to self-regulate, and as the parent has learned strategies, and from direct therapy, that it's pretty much, it depends on the level of severity that they start with. You know, like children with autism, many times it's definitely decreased, but they still may have some issues with it, you know. But for a lot of the kids, that's why we like this program DAA, which is filtered music. It's a very intensive 10-day program, but it has really been great for decreasing sound sensitivity. So I've had kids who could not go to a birthday party, could not go to a parade, could not go to a public bathroom because of the toilets flushing, and now they can do all those things without problems. So, you know, children with dyspraxia, I can say that I've resolved some of those issues. I mean, the child is very successful, more coordinated. I mean, if a child has a severe coordination disorder, they may not be an athlete, but they at least can ride a bike now and do PE without being horribly taunted.
Stop spilling their milk and
Yes,
running the walls.
yes, and being the kid that everybody's like, oh my God, you know, and just PE is a nightmare for 9-year-old boys with this going on, nightmare. You know, I have a little boy right now who, I mean, he's so smart, brilliant, but he hates school. I mean, he's been from school to school to school, he cries every day, you know, and it's, I just started working with him, so he's 9. So as long as I get him when they're 9, I wish I could have had him when he was 3. You know, the earlier we get them, the better we can improve and really remediate the problem. But they can have a lot of success, especially for these kids who it's kind of subtle, you know? It's like it can really affect them, and then if you can get rid of the problem, they do really well. They do really well.
I have a question. Do you have an average amount of sessions as far as?
Well, it depends on kind of the rate of their progress. Like if they come twice a week, you know, or 3 times a week, we see a lot faster progress. Sometimes it's the parents, just whatever the insurance company will cover, they'll do that, and then, you know, they can still benefit tremendously, but we may not go until the child is perfect, you know. But it depends. I mean, a lot of times it's like, if it's just sensory processing disorder, maybe 6 months to a year. If they're, you know, younger, like 3, 4, 5.
And then the parents, at least, and it's, you know, not in the sensory area, but just overall with any type of therapeutic intervention, or like,
How
you know,
long?
what are we looking at? How
Yeah.
long is this going to take?
Well, and usually we can tell them a little more once we do an assessment. You know, once we do our evaluation, we can say 6 months and everything should be fine. But a lot of times, a child starts here with a reading problem. And so they see our speech pathologist and they get evaluation, and then other things start to show up. Well, handwriting's a problem. And then we start asking questions about sensory stuff, and sensory stuff starts to show up. So then they might refer them to us, and so then it kind of progresses just depending on what we keep finding. So some kids have been here a long time. You know, I mean, you see children who have severe learning disabilities, and, you know, it can help with that. Sensory can help with that, but for the most part, we see probably like a year, 2 years for kids with a little bit more. Anything else you think of? Do you all see a lot of parents who have some of these concerns? You do?
Probably one of the difficult parts is when they have the real sensitivity to sound or crowds and that kind of thing. They're very anxious children, and they're hyperactive in the classroom. But the hyperactivity is really based in the anxiety and the sensory. A lot of times they're not patient to work through it.
Right.
On those ends, the teacher's complaining, they're finding that teacher said their child has ADD, that's what we think is going on.
Right.
When you try, let's kind of try to push through a little bit.
And
those
let's
are the
look
ones
at
that
it
are
and
tough.
see. Well, and sometimes if it's a true anxiety disorder, even when we remediate some of the sensory problems, we still see a really high degree of anxiety. And so sometimes the best outcomes are with both. You know, when we treat this and we treat the anxiety too.
But they're looking for ADD as the answer.
Right, oh, I know. It's a lot quicker and easier. And like I said, some parents, if they've come here and we've assessed them, and I see a lot of sensory issues, then I'll say, we can try, you know, using these strategies, doing therapy, let's say 6 months, and see if it makes an improvement. If it doesn't, then it's probably more ADHD. And you know, there's some OTs who are very anti-medication, that kind of thing. I'm not, as far as, you know, let's work together. We see the best outcomes with the psychologist, the psychiatrist, the therapist, the teacher, the parent, everybody working together and sharing their information and getting it right. You know, if we can even titrate when the medication is given within a sensory diet, you know, and then if there's learning difficulties or handwriting is hard, or, you know, they can't ride a bike and whatever, and we really facilitate improvement in those areas, then the child does really well. You know, so I try and think of it as it can be a lot of things, and you just have to, you know, But I try and explain to the teachers that, you know, I mean, and this week has been really bad as far as I've had like 6 parents desperately calling me saying, I don't know what to do. You know, like they can't stay, they're freaking out in the classroom, and we thought they were ready, and, you know, like, it just depends on the teacher. There's some teachers that are like, I'm willing to do anything to help this child stay here, and there's some that are like, this isn't gonna work. There's no way I can teach these other kids, and so sometimes I wish I could just go with the child and stay for the whole week and then leave, you know? Because a lot of teachers are not educated on it, and just understanding it can help with knowing how to handle it. And, you know,
They'll interpret the let them chew the gum as, you know, what are we doing to our children? We're just letting them do whatever they want.
right,
Try to get them to behave.
exactly. And then I'll say to them, what if somebody didn't let you have your Coke and your little chips at 10 o'clock? How would you feel? You know, I mean, they do all kinds of sensory things
Right,
all day
right.
long, and our kids need it even more than they do. So, you know, I try and tell them, we don't want to turn your classroom into a romper room, but at the same time, you know, have a basket of, like, they'll give out peppermints during standardized testing because it helps them pay attention.
Helps them get their scores.
And they get better scores. So I'm like, well, what about, you know, every test? Or, you know, you just have to be able to organize how you distribute it and how you do it. And then another thing I get a lot of times is, well, that's not fair to the other kids. They're gonna want that, you know.
I
And
knew
so,
it. I was waiting on you to say
Yeah.
that. I knew it.
but I tell them a lot of times, okay, not everybody in here needs glasses, so not everybody in here has glasses. But if he needed glasses, and we said, you know, you said, well, not everybody else has glasses. So you have to try it. I find if the teacher can tell the kids what this is, you know, or just have a couple available. They know who needs it, you know, and if the kids pass it around, maybe sit on a little cushion for a little bit, whatever, it's not novel and they don't need it, and they're not gonna worry about it anymore. You know, but if you make it a big deal, you know, then it can cause problems. But I mean, like, we've had, you know, the therapy ball in the classroom, you know, we've had some great teachers who have tried different things like that. A lot of times it's the teachers quickly to say it's too distracting, you know, we can't have it. So they have the cushions, and they have a lot of different alternative seating now. And we have catalogs that have a ton of new, you know, seating options for teenagers, for home. They have this new desk that you can stand at, but also sit and tip back in a chair. You know, so they have all these things that are pretty interesting. If I could just find a school that would let me go in and, you know, try some of these things out. Like, I'd love to get one teacher who's really great with this and interested in this, and we could just do like a little project for a year, you know, and see what would happen. But, you know, I'm trying to get out there. Private schools, I don't have too much luck with, you know, I really don't. So we try and do what we can behaviorally, and, you know, here, working on helping them follow structure, and, but anything we give, if we can tell them, you know, if you see them kind of getting overwhelmed, let him go get some water, or just, you know, need a break. Sometimes those little breaks can make all the difference in the world. And we're pretty open with having teachers email us, call us for information to keep going with it. So we'll see how these 6 children that I'm dealing with right now go. But I also put in here one for sensory defensive adults and adolescents. So just some little recommendations and accommodations for them.
Can you talk a little bit about, I've heard of the trapeze and all the different things that these will use for sensory integration. Talk about what
that
you do
does.
and what that does.
Well, from a modulation standpoint, we talked about kids who are over-responsive, under-responsive. It helps them to be able to process it more accurately. So we do a zip line, which is linear movement, and it's proprioception because you're hanging, okay? And then we might put targets for them to land in, and that's called a projected action sequence. So like catching a ball is a projected action sequence, riding the zip line, landing a tire, throwing a bean bag. All of those can work on timing, coordination. But as far as like if it's a child who's under-responsive, then if they spin, they're getting more input. So they might hang upside down. We're going to give them opportunities for intense vestibular input. So their brain starts to register it with less and less intensity. See what I mean? Now, if it's a child who's oversensitive to movement or to touch, we're gonna do things like encourage them to try, but you have to know how to scaffold it, and you have to get them to trust you, and then you have to make it what we call the just right challenge, which is where it is a challenge for them, but you set it up to where they're gonna be successful. And so they start to really experience success. It's an art to it really, on how you get them to be able to do this kind of thing. So the scooter board, we can use for spinning, we can use for pulling themselves up the ramp and going down the ramp. You're doing a lot of vestibular, and you're working on the neck and back muscles. So for those kids with postural disorders, that's going to help give them a more stable base for moving their eyes. Like we have a lot of kids who have trouble with reading because they don't have a stable base of support here from which to move their eyes in a coordinated way. And so and for a lot of our kids who need movement, we can get them to do puzzles and cognitive activities by spreading things out on the floor and having them use the scooter in different ways. So for motor planning, if you could see a dyspraxic child get on a scooter board on their stomach for the first time, you have to see it to really get a clinical picture, but it is like painful to watch, you know. And I've had kids who they'll get on the scooter board, and if they're trying to turn around, they turn their body. Like they get up and turn their body. They don't have a concept that the scooter is an extension of themselves and they can turn around. But so for kids who need movement, we'll do activities like we're trying to integrate visual and auditory and vestibular. So we might put them on this tire swing, and we might spread letters all around them, okay? And we might call it a spelling word. And while they're moving through space, they have to locate the letter, throw the beanbag on it, get the next beanbag, you know. So we're trying to integrate different sensory inputs at the same time for an outcome.
Sounds fun.
It's very fun. And I mean, with the children with autism, there's a lot more going on. And so a lot of times we look for what they prefer, because kids who don't engage very well, if you put them in the lycra hammock, and we'll show you all the gym, but if you put them in the lycra hammock, you're blocking out this extra visual input, and they love the movement and they love the pressure. So I can bounce them and sing a song, whatever, and then when I stop and open it, I'm likely to get eye contact or a verbalization or an attempt at something because they want it so badly. It's so motivating. Like the zip line is one of the first ways I get nonverbal kids to be verbal, because they cannot get to it, but they love it so much that I will get, you know, throw me the zip line or go or more or anything. So we use it in that context too. It just kind of depends on what we're using it for. But for dyspraxic kids, all those different pieces of equipment, we're trying to teach them how to figure out there's lots of different ways that I can move my body in relationship to objects or use them as extensions of myself. For tool use, you know, kids who can't cut with scissors, and it's more because they can't figure out how to place their hand, they can't discriminate where their hand is in the scissors, you know, then they can't motor plan opening and closing the scissors, and so we might start off with bigger tools. You know, we have these snowball scoopers, but they open and close, and they pick up balls, and they drop in the bucket, and we add all kinds of cognitive and academic kind of games within that context. But we're going to give you all a tour and see, so I can see the big fun gym. And the gym is very motivating. I mean, we can get them to do lots of stuff. Sometimes we use it to prepare them for a session, and they do much better sitting and doing table work afterwards. And then sometimes we use it as a reward, and they'll do whatever we want them to do to get to go to the gym.
Where's your gym?
Oh. I know, and the speech therapists don't like us very much either, because the kids want to go to OT because it's fun. So I know that was quick, and I mean, you know, we could spend days on sensory processing, but we have like an hour. So, but any time you have questions, you have a child that you're seeing and you kind of on the fence about, you know, you're welcome to call me, and I can kind of ask you some questions to see if we can figure out if that's what's